دكتور حسين شعيشة from المنصورة يونيفرسيتي. والدكتور حسين يعني من الناس اللي فيري اكتف في الجمعية، والواحد فعلا بيسعد كل الاكتيفيتيز اللي بنعملها ومقدمه في مجال الترانسبورتيشن والدياليسيس والسكريننج والإديوكيشن بروجرام. يعني من الناس فعلا النشيطين جدا. هيتكلمنا على الهيموجلوبين فاريابيليتي ونحاول نسيب كما عودتنا.
ده طبعا يعني اسعد الاشخاص على تقديمنا يعني اشكر كل الناس الموصله خصوصا الدكتور حسين يوسف، الدكتور ماضي، الدكتور طيب، كل يعني
ومجدي الشراوي
طبعا الدكتور مجدي لوحده. الدكتور مجدي طبعا يعني اداني الشرف ان انا اشارك في المؤتمر ده، اتمنى له نجاح وتوفيق. قبل ما ابدا البرزنتيشن بتاعي بوجه سؤال بس للاودينس، هل الهيموجلوبين فاريابيلتي دي شيء مهم ولا شيء اي كلام؟ يعني شيء المفروض يتعمل له محاضره في الكونفرنس ده والناس تبقى عارفاه، ولا ملهاش قيمه قوي؟ اللي موافق ان لها قيمه وتافكت الاوتكم اوف ذا بيشنتس يرفع ايده بعد اذنكم.
اجماع.
طيب يبقى اذا انا المحاضره بتاعتي اشكر دكتور مجدي شرقاوي تاني انه حطها، لان انا هتنتهي البرزنتيشن، انا ممكن انهي البرزنتيشن كده ان ملهاش قيمه، لكن انا هتبقى طول البرزنتيشن هيبقى تور ازاي بشخص الفاريابيلتي وهل لها قيمه ولا لا. فهبدا البرزنتيشن ان شاء الله تقسيم للتايم. This is my agenda. I am focusing on introduction, just a few slides. What about the definitions and the use of variability, the impact of variability on patient outcome, some questions and answers, and I'll end final conclusion. I start with this slide. This slide is carries very sad news because the 5-year rate of survival of patient dialysis is very poor. And it is even poorer than prostate cancer, thyroid cancer, breast cancer. This slide carries a call for all of us to improve our service. And yesterday, Professor Tariq Elbaz mentioned what the difference between effective and efficient therapy and how to reach the outcome. So effective means dialysis service is available in the community. We have many machines, many centers, and efficient therapy, it is different than the effective treatment. So we should move from effective to efficient, targeting the optimal treatment and to save the patient life and to offer them quality of life. This one of the post-hoc analysis of the virus study showed that the higher hemoglobin level above 13 grams per deciliter, especially in smokers, carry poor prognosis and poor outcome for any disease development and infection death. The use of ESA is relevant all over the world. From United Kingdom, the majority of patients on dialysis are treated with ESA therapies. And this is the cost of the treatment. The majority of the cost burden given to the patients by the drug is to cover the ESA treatment. This is approximately $1.5 billion just for treating ESA therapies. What's the definition of how to diagnose variability? There are many methods to diagnose variability. I concentrate only on 4 types: the standard deviation, residual standard deviation, fluctuation across thresholds, and hemoglobin cycling. What's meant by standard deviation? Standard deviation is the variance from the mean, and this is, if you look here, these are 2 patients, the patient A and the patient B. The mean hemoglobin, which is you submit the values of hemoglobin both through the readings and then divided by the number of readings. This is the mean. If you look here, the mean here is typically the mean here. But what's the difference between patient A and B? The vertical variation from the mean is different from here to there. So variability here is more than variability here. The standard deviation doesn't give us idea about the regression and the trend for increasing or decreasing value. So residual standard deviation gives us this trend. So this in the person A and the B, we find here the patients from the beginning there is increasing trend toward the higher hemoglobin in this patient and this patient. But if the trend is typically increasing, you will find standard residual standard deviation 0. But here, although there is a trend toward increasing hemoglobin in most patients, there is some variability in the reading in each month. What's meant by fluctuation across threshold? It gives ideas about the treatment. If we put a arbitrary line here, this is for the upper level and this is the lower level. So if all the values are consistent between the above and the lower level. This is was known as consistently middle range, and this is for our, if we are following the first one, this is an optimum. Although this, here you can find many variability, but the variability is still inside the box of consistent mid-range. Here is completely different, but the same mode. So the fluctuation across the should give idea about the pattern and algorithm of the management of anemia. If you go to the second part of the slide, you will find another terminology, which is amplitude. What is the definition of amplitude? Amplitude here, if you look, concentrate, you'll find the majority of readings are here in the mid-range, but here there is one reading below the lower range. So here there is amplitude. So amplitude is defined if you have reading inside the box and reading outside the box, there is an amplitude. And this amplitude is classified into low amplitude or high amplitude. If you look here, the only reading outside the lower range, no reading above the upper range. So if the reading is just below the side of the range, this is low amplitude. If it's moving below the lower range, it is low hemoglobin, low amplitude. If it is moving to above the upper range, it is low amplitude, high hemoglobin. So this is the difference. If you find the reading above and below the box, this is high amplitude, irrespective if there is values, if there are any values inside the box. So if you have values above, values below, this is high amplitude. In Bertin analysis, there are 6 patterns of variability. It's the same like hemodialysis. If you look here carefully, you'll find the values here below, value above, this is high amplitude group. Here no amplitude because all the values are above the threshold of the treatment, above the above level of the treatment. So this is high group. Target group, all the values are included within the box. And here, low group of hemoglobin, all the values are below the lower range. And the first one is low amplitude, high hemoglobin. Here there is amplitude because there are some readings above the range, but it is on one side only. And here it is low amplitude, low hemoglobin because the variability is toward the lower range. So these are principally 6 types, 6 patterns of hemoglobin variability in Bertin analysis. It is what's meant by cycling. This is the fourth slide. If you look carefully, the cycle constitutes these readings: decreasing excursions and increasing excursions. So if you follow the readings for 4 months, you find the pattern decreasing from 11.7 to 10.2 and then 9.4. This is decreasing excursion. And then from 9.4 to 9.7 to 11, this is increasing excursion. So the cycle is principally constitutes of 2 waves, decreasing and increasing. Each wave is 2 months. So the complete cycle is 4 months. Half of the cycle for decreasing excursion and the second half for increasing one. So these are principally the definition of variability. So simply variability is you have multiple readings that are not similar to each other. So if there is any impact for variability, if you look at this study, and this is including a large number of patients, you'll find the high variability. Here, no variability from 0.8 to 1, and then these are the variability, and here above 2 gram variability. And this study showed that the higher the variability, if the variability exceeding 1 gram, the higher the adjusted hazard risk of mortality. So this study showed that variability is important. Take care when you read any study, you should critically appraise the study. This is an observational study, and any guidelines or extrapolated from observational study is weak evidence studies. In the pre-dialysis CKD patient from Chinese, the variability is working and it affects the outcome of the patients and increasing the percentage of in the CKD disease development if there is variability exceeding 0.7 gram. Even in transplantation, there is hemoglobin variability, and the higher the hemoglobin variability, the higher the mortality and the lower the graft survival. Okay. And this is the data of transplantation, they commented that it is not the hemoglobin figure, it's not the ESA treatment, it is variability. So all the previous studies are trying to convince you that the variability is working. But is it simple like this? The answer is no. So hemoglobin variability can adversely affect the outcome, as I mentioned, but take care because there are many publications showing no effect on the outcome. If you look carefully to this data, it is a matter how percent the patient is below the lower range. So if you are not targeting the proper hemoglobin, this is the most important issue, to know the variability. And this study including 159,000 patients. Another study showed that it is not independent, and the presence of comorbidity affected the results. So it's not the matter of variability, it's the matter of comorbidities associated with hemoglobin variability. If you look to this study, you'll find that if you adjust the analysis, you'll find the only group of low, persistently low hemoglobin is associated with high hazards of mortality. Even in the analysis, there is no difference between all the classes of variability. So all these studies show that variability doesn't work in patients and doesn't affect the outcome. So I think Professor Hani Hafiz mentioned the resistance perfectly, and this is to improve the surface of anemia, we should tackle all these issues. I'm not going to discuss, but one point I want to add to the resistance is the testosterone insufficiency in patient dialysis. You'll find here the data, approximately 23% only of the patient dialysis had adequate testosterone levels, so we should take care of andropause in elderly men, especially if they have poor appetite and fatigue, because you can find the secret in the hypogonadism. One of the important questions is variability associated with specific type of ESA therapy. What's your expectation? If there is any difference regarding the use of certain type of ESA and the occurrence of variability,
should be.
It is expected, but the study showed no difference. If you follow your patient perfectly, it doesn't matter which type of ESA you are using. How to overcome the variability or the target the proper treatment for anemia? As Professor Hani mentioned, that we can use the computer program, but one of the important issues is the presence of pharmacists who are dedicated to properly monitoring and change the dose of the patients. So this study showed that if you have in your facility a dedicated pharmacist, this makes a great difference. And currently we have in many medical schools in Egypt the program for clinical pharmacists. The computer program, as Professor Hani mentioned, can help. And another point is to follow the hemoglobin and the hematocrit during the dialysis and to treat the patient properly. Another question, if you use low flux dialyzer versus high flux dialyzer, doing here conventional hemodialysis and here hemodiafiltration, does it make any difference in treating anemia and to decrease the variability? Yes or no? So which is superior, high flux or low flux? Hemodiafiltration or hemodialysis? The answer may be expected toward the high flux hemodiafiltration, but the answer from the study, this is randomized study, no difference. So just to sum up, these are the guidelines approved from the FDA that is recently published. Is ESA label changes for the safe use of ESA in dialysis. Initiate ESA treatment when hemoglobin is below 10 grams per deciliter. If hemoglobin level approaches or exceed 11, reduce or interrupt the dose of ESA. When initiating or adjusting therapy, monitor hemoglobin, and this is most important, crucial step. Whenever you change the dose, whenever you interrupt the dose of ESA therapy, you should shift to monitoring the patient weekly, it's not monthly. You follow the patient monthly in a steady state only. For patients who don't respond adequately over 12-week escalation period, increasing the ESA dose further is unlikely to improve response and may be deleterious. Adverse events should be registered, and this is the most important invitation for our society is to register everything. And I'm happy that I listened to the Professor Gamal Saad announcement that there are something in the guideline regarding these registers. And this is an editorial review. that was published last year, discussing variability and how to apply strategies to decrease intra. So this intra means that reading from the same patient, variability in the same patient, and inter-patient between the different patients in the unit. This slide is extrapolated from the Professor Sobh lecture in the International Dialysis course last year in 2011, showed that the hemoglobin goal is the safest is between 11 to 12, and if you exceed 13, the harm is there. If you are below 10, the risk is there, and the gray zone is these two zones. This year, when I present this slide in the course just 1 week ago, we just decreased the safe goal from 10.5 to 11.5. So if I'm working with a young patient who want to be active in the lifestyle, I can go to higher levels, so 11 or 11.5 is okay for this patient. But if I'm dealing with elderly patient, 10.5 is okay. So this is a very nice pyramid, and it's recently published showing that you have goals in your treatment. What are the goals in treating anemia in hemodialysis patients? We have 3 goals. Unvalidated surrogate endpoints, to which hemoglobin level, so hemoglobin level is not so important beyond a certain level. So the patient to attain level above 11, there is no data to document the safety, even there are some data to document the hazards of this issue. Another endpoint which is very important is to avoid blood transfusion, and the most important is the top of the pyramid, to decrease mortality, to offer a better quality of life. If we exceed, or if we are treating the patient before dialysis and CKD and to retard the progression, it will be a nice goal. If we avoid the vascular access thrombosis or to improve the cardiovascular outcome, this is really the goal of our patient. And by this way, we are centering our treatment to increase relevance to the patients. So this is a patient-centeredness approach, and to individualize our treatment. So without goals and the plans to reach them, you are like a ship that has set sail with no destination. يعني السفينة أقلعت مش عارفة رايحة فين. The variability is nothing to be put in mind, but we should put in our mind to observe our patient, to keep eye on the hemoglobin, to follow serially our hemoglobin. When we interrupt or modify the dosages, we should monitor hemoglobin weekly. And I want to conclude my presentation by this statement: whenever you want to achieve something, keep your eyes open, concentrate, and make sure you know exactly what it's you want. No one can hit their target with their eye closed. I want just, before leaving the presentation, to announce the activity of Egyptian Society of Nephrology. يعني السايت موجود وراشد يوم 6/9، وطبعا ده نشاط جميل ومحمود لا، ما هو انا مش هشغل الفيديو حالا. فانا ارجوكم جميعا ان احنا نتعاون، لان بدون ايد واحده القصه مش هتمشي. فالناس سالوني نعمل اكونت ازاي، فانا مش عارف الفيديو مش ممكن نضغط على الCNE من موقع الجامعه المصريه، ده هيعمل لنا شيفت الموقع بتاع الفيرتشوال اكاديمي، وبعدها نكريت اكونت. وبعد ما نكريت اكونت هنمشي في الخطوات. لو في اي مشكله حصلت في الخطوات ممكن تبعتوا لي على الايميل او تبعتوا تكنيكال سبورت هيجي لكم اجابه. وما تبقى معاك يوزر نيم وباسورد تخش تقدر تنزل كل الحاجات. وانا نفسي ان احنا نتفاعل اكتر في الكونسلت اكسبيرت سيكتور. نعم. والمؤتمر طول ما يعني بيقول له خبر صار ان المؤتمر ده ان شاء الله بكره باذن الله لما اروح المنصوره هنزله على الموقع، يعني يوم الاثنين الصبح هتلاقوا كل المحاضرات بتاع المؤتمر ده موجوده اونلاين، تقدروا تنزلوها برضه. انا عشان ما اطولش هكتفي من الفيديو ده كده. واللي انا عاوز اختم بيه بقى لغه عربيه بفضل التعاون. يعني الدكتور مجدي الشرقاوي حط محاضرات على المالتي ديسيبلينري تيم ابروش. المالتي ديسيبلينري تيم ابروش يساوي كوبريشن اند كولابوريشن. في فرق بين كلمه كولابوريشن وكولابوريشن. كولابوريشن يعني كله يعني بيشتغل مع بعض وهاند ان هاند عشان تارجت الجول بتاعنا هو امبروفنج السيرفيس سواء اديوكيشن او بيشنت كير. انما كولابوريشن كل واحد بيشتغل ويضرب في الثاني، كل واحد ضهره للثاني. فبفضل التعاون ارست صروحا من المجد فوق القمم، فلم يبنى مجد على فرقة ولن يرتفع باختلاف العلم، مع المعالي يدا باليد نشيد البناء بكل الهمم وكل الايادي اذا اجتمعت دنا المجد حتما لنا وابتسم، واحنا نستحق فعلا، مصر تستحق الكلام ده. بغير التعاون لن نرتقي، ما هي تو بي او نوت تو بي، وليس لنا ذكر بين الامم. كفايه حصل، احنا كنا على قمه الامم وبقينا دلوقتي في الدين، فلازم نطلع تاني ان شاء الله. وده في الفاريابيلتي وبالتعاون. لو انتم بصيتوا هنا ايه الصوره دي؟ الصوره دي من جوجل. النمل عاوز يعدي الماء ده، البحر ده او الترعه دي، الشباب كلهم مع بعض شالوا بعض، وبالتالي قدروا يعدوا البريدج، عملوا كوبري وعدوا. وده اللي عمله انور السادات والجنود في 6 اكتوبر، والنهارده 6 اكتوبر. واسيبكم مع